Hello. Whoa, that works. Welcome, everybody, to the ONC Consumer eHealth Town Hall. I know, it's just after lunch, but okay. Woohoo! So, I'm Lygia Ricciardi. My unofficial title is Consumerista. What that means is I support patients and consumers, as does this amazing team of people, within the ONC context. Officially, I head up ONC's Office of Consumer eHealth, which was created last May, which is really exciting because it means that ONC has made a structural commitment to really supporting consumer and patient engagement in health and healthcare. Woohoo! All right, so basically, you guys are all, I assume, we're pretty familiar with ONC? Okay, we'll take that as a yes. The Office of the National Coordinator for Health IT, we're the folks that are working on the federal side at spearheading a transformation of healthcare into Century 21 by encouraging providers and hospitals to adopt health IT, and now patients as well. So this is a town hall. We have an hour and a half, and the idea is we want it to be a conversation. So what we're going to do is start off by telling you a few framing things, some basic remarks about why we think consumer eHealth is important and consumer mHealth. We're going to talk about the underlying strategic approach, and we're going to tell you, at least sort of give you a taste of, a lot of the actual projects that we're working on. But then we're going to open it up for questions. So we're going to go fairly quickly, and we really want to hear from you. I do want to note that we had a Twitter chat last Thursday in preparation for this, and we definitely keyed up some really interesting topics that we'll circle back to today. Folks shared some really excellent resources, so thanks for that for everyone who is in the room. And by the way, we encourage you to tweet today. Many of us have our Twitter handles on our slides. So before we get going, I would like to briefly go down the line and introduce this amazing crew of people that are here to share with you what they're doing. So Pierce?
Yep. Pierce Graham-Jones. I'm the West Health Innovator in Residence in the CTO's office at HHS. But I was with ONC for a couple of years, so I guess I still count here.
Hi, everyone. My name is Ryan Panchadsaram. I'm one of the Presidential Innovation Fellows on the Blue Button for America project. I'm working very closely with the ONC team on this. Here's Damon.
My name is Damon Davis. I'm Special Assistant in the Office of National Coordinator, and I work in our Consumer eHealth program.
Hi, I'm Henry Way, a Presidential Innovation Fellow based at the Department of Veterans Affairs, working on Blue Button for America.
And I'm Erin Petter-Seminario, and I'm with ONC. I'm a policy analyst in the Office of Consumer eHealth.
I just have to say, just kind of bragging for a second, that U.S. CTO Todd Park has called this team the Dream Team. This is like an awesome lineup of people. So, I think many of you are already sort of bought on to the idea of consumer engagement and patient engagement, and I know you heard from Donna Cryer and Marianne Sterling this morning about the importance of patient and consumer engagement. It's certainly a theme that's come up in a lot of the talks and presentations I've heard. I wanted to take a minute and talk about why it matters to me personally, or one example. This is a picture of my baby. Her name is Ada Rose. She was born about 3 years ago, and she had a hole in her heart, which meant that the providers who were caring for us were really concerned that it might impede her growth. Basically, blood is deflected where it shouldn't be so that the brain might not grow and develop it as it needs to be. So we spent the first year of her life, my husband and I, going to different healthcare providers and with her undergoing tests, and them saying, like, really at any minute now we may recommend open heart surgery because we're really worried that this hole is going to have a negative impact. Finally, they said, it's time. Your kid is simply not gaining enough weight. It's going to have a negative effect. Let's go sign up. But we didn't. Why didn't we? Because all along we'd been doing internet research, we'd been getting online in chat rooms with other parents, meeting some in the real physical world, talking about this condition, graphing her weight, comparing it to things like international norms for weight growth. It turns out American babies are a lot heavier than, say, French babies. So on the American scale, although our baby was a total lightweight, in France she was like just fine. So we got another opinion, and in short, we avoided open heart surgery that turned out to be unnecessary, thus saving trauma, risk, and roughly $100,000. So that's one example of patient engagement. Here's Ada, more or less now. She's a big girl. She's healthy, happy, very robust. So there are many examples of patient engagement in health IT. Again, we are within the general context of ONC, the Office of the National Coordinator for Health IT. I do want to point out there are a bunch of seats in the front. Don't be shy. We don't bite. Come on in. It's okay if you come and sit and then you want to leave later. That's okay. So basically, I just wanted to share this slide to indicate that patient and family engagement is something that is really built into what ONC does and how it is driving general modernization of the healthcare system forward. Patient and family engagement is one of 5 key strategic goals. Again, not just for ONC, but for policies that are meant to guide the entire federal government. And it's, this idea of modernizing the healthcare system and moving us all to health IT has been working, as you know. In the last 2 years, you can show that the growth in EHR adoption by providers and hospitals has been greater and has taken place at a greater rate than ever before in the past. We're now at roughly the 50% mark, which is pretty impressive. But there's a lot going on in the outside world, too, which we think has huge bearing specifically on the patient and consumer side of things. So I know I'm preaching to the choir on this, but we're in the middle of a technological revolution. People are using new technologies, including mHealth. The demand for information in general is growing. People are searching for all kinds of information on the internet, and healthcare has always been one of the sort of top areas of interest and continues to be. In addition, people are searching for information not just from sort of trusted resources, such as official resources, like peer-reviewed journals or even sites like WebMD, but from each other. People are getting online in communities and sharing their own personal experiences and learning from each other. All of this is taking place, all of this kind of private sector change and social change is also within a context of policy change. As you know, through health reform, payment models are changing such that it's likely that consumers will have a much greater responsibility for the financial aspects and other aspects of their care than they ever have before. So in this context, I think there's really incredible potential for the growth of consumer engagement in health and healthcare. We've got some stats on the left and the right that show that there's really a contrast between where we are today and where we could be. Sort of on the kitten side on the left, we've got some stats that show that the growth of things like personal health records hasn't always been so quick, and yet on the right, there's all this potential. 80% of people who use the internet are seeking health information online. The use of mobile for health has doubled in a year. People are saying the majority would like to get access to their health records or use a smartphone to monitor their health. 65% are interested in using a medical device to monitor their condition. So I think in part what we're doing at ONC and through meaningful use policy, among other things, will start to change that pattern so that hopefully, we'll get we'll be able to show a slide of a lion looking at a lion next year or in the next couple years, real realized potential. Why is this important? You know why it's important, because so much of our health and our outcomes and our well-being depends on everyday decisions. Only 20% or 30% of outcomes are based on what happens within a healthcare setting, and the vast majority is really outside. And that has real impacts on the quality of care, too. I mean, you can see here, I know it's hard to read in the back, but basically yellow indicates more activated patients. Blue indicates less activated patients. So what we're looking at here is rates of things like hospital readmission within 30 days. If you're an activated patient, 13% get readmitted. And this was a study that came from AARP testing people, or the study group was people over 50 who had at least one chronic condition. Folks who are less activated are much more likely to end up readmitted to the hospital or experience a medical error or suffer a health consequence from poor communication among their providers. So this stuff really matters. What can you do with health information technology, whether it's mobile or not, as a patient? You can help to coordinate your own care. You can take your information and share it among the providers and others who are working with you, caregivers. You can better communicate with your providers, whether it's using text or an email or whatever it is. Digital communication allows you to be in touch on an ongoing basis rather than waiting for those episodes of care that may come about relatively infrequently and do for most of us. And the other thing, of course, is that you can manage your own health and wellness. And this has to do with everything from, using apps and tools, perhaps, to help you remember to take medications or to track how you're doing with respect to a particular goal. Maybe it's keeping your blood sugar under control or losing 5 or 10 or 50 pounds. So where does ONC fit with all this? We talked about meaningful use policy, and we'll come back to that in a little bit. And that's certainly one of the greatest levers that we have. In general, however, in the patient and consumer area, I think some of our greatest power comes as catalysts. This is not a revolution that we are leading. We are trying to support you and the private sector as you lead it. Consumers, patients, others. We're trying to pull you together and create opportunities, some of which you'll hear about shortly, to network with one another, to share best practices, and to really kind of pull together sparks so they can ignite and burn into a greater flame. So our strategic approach, the way we think about this big really consumers and health and technology is potentially touches on so many different things. The sort of mental model that we use to organize it is based around our 3 A's strategy, as we call it. So the first piece is access, and that means we really want to give consumers electronic access to their health information. That ties to meaningful use policy. It also ties to the blue button, which you'll hear about. The second piece is action. We want to catalyze the development of tools and services so that when you get your blue button health information, you can put it somewhere. You can plug it into apps and tools that let you make sense of it, interpret it, and most importantly, act on it in some way. And the third A has to do with attitudes, because we realize that encouraging consumer or patient engagement isn't so much a technology challenge. It is in some ways, but it's also, it requires a change in thinking and a change in culture. There have been traditional sort of ways in which providers and patients have related to each other for generations. Often, you sort of imagine the provider saying, just take 2 of these and call me in the morning. And you don't necessarily think of it as a dialogue, a give and take, in which each party brings valuable information to the table. And we think that particularly through technology, we can start to change and really grow that relationship so that in many cases it's much more of a shared endeavor rather than sort of a one-way street. So in the attitudes area, a lot of what we do is inform people about the fact that they have rights to access their information and the value of doing so. And we encourage them to say, it's okay, it's all right to ask for a copy of your medical record, or to say, doctor, I'm not sure that applies in my case, like me and my baby, Odd but true. In my family, my grandmother was actually required, sort of prescribed, eating chocolate bars before she could go to college as a freshman because she was underweight. So they were like, this woman has to gain weight. I'm not saying everyone in our family is thin, and I wish it were easier for me to be, losing a pound or 2. But we come from light people. My kid wasn't abnormally light for us. She might have been abnormally light for another family, but she was totally okay. And that's information that only I would have, not the doctor. So, just want to touch a little bit on meaningful use again, since it is one of the most important levers that ONC in general has for changing the health IT landscape. Essentially through meaningful use, we're going through a progression of stages. Some of you, I'm sure, are quite familiar with them, although others may be less so. And we're, first of all, trying to encourage providers to digitize their healthcare information and then share it, and then really derive lessons and improve quality through aggregating it and learning from one another. And from the beginning, we've tried to bake in elements that really support patient and family engagement. So in the first stage of meaningful use, we required that patients have access to a post-visit summary. That means you go in to see your doctor, you go to the hospital, and you can get a simple printout of what happened. Just a summary for you, which changes the model. If you're not used to that, it's sort of like getting a receipt when you go buy a cup of coffee. It shows what happened, but that's kind of a new thing. It starts to change people's thinking. Stage 2, the Stage 2 requirements for meaningful use were required last summer, and they really build on that, not only by paving the way for secure patient messaging, such as text messaging, But really importantly, requiring that providers have the capability and that EHRs have the capability to enable patients to view, download, and transmit their data. What does that mean? That means just logging into a portal and looking at your stuff is not enough. You have to have the capability to be able to take that data, download it in digital, computable form, and plug it in elsewhere. You might just choose to email it to someone else, another provider, or you might choose to plug it into an app or a tool and mash it up with other data and do something else with it. But really the idea is that you can own and use your data. You're not as an individual captive to an audience, whether it's a provider or payer with whom you do business. And stage 3 is yet to be determined, but I'm hoping maybe some of you will weigh in on this. There is a request for comment that's out currently that looks at things like, how should we think about taking data from patients and incorporating it back into the record? How can we figure out how we can learn from patients if they see something in the record that's missing or perhaps an unintended error? So those are the kinds of things that we'll be wrestling with in stage 3. One other thing I want to say about stage 2, about this view, download, and transmit thing. Not only are people required to do it, but providers are required to reach a certain threshold of their patients that must be doing this. 5%. Some people think that's a high number, others think it's a low number, but the point is that providers are actually accountable for making sure that a certain amount of this kinds of transaction occurs. So with that, I'm going to turn the mic over to the first of my fabulous partners in crime.
Okay, great. Thanks a lot, Ligia. I was at this conference last year, and I think one of the biggest challenges that I heard, at least again and again, was access or a lack of interoperability and access to personal health data. That seems to be a major barrier right now for a lot of mHealth developers, and I think there's a lot of reasons why those barriers exist, but it makes sense. There's been 3 things at HHS that I think have really taken off over the last year that are helping to address that barrier. Meaningful uses, stage 2, view, download, and transmit requirements. The momentum the VA has created around the Blue Button Initiative, and Henry and Damon will talk more about the broader Blue Button Initiative in a bit. And then our Automate Blue Button Initiative, which Ryan and I are going to talk about today. So the Blue Button is about ensuring that everybody, every American, can access and use their health data. Since its inception 2 years ago, Blue Button has stood as a brand and a common set of guidelines for data holders to follow if they want to give consumers easy access to their own personal health data. I'm going to give a little bit of a background on how this fits into the government's health IT strategy, and then Ryan's going to discuss the new technical guidance we've been working on for Blue Button. I'm just going to click through this part. There we go. So the VA started Blue Button in 2010 as a sort of a minimal viable product for solving the problem of consumer access to their data. They added a button onto their health portal, mHealth, which gives consumers a simple electronic download of the clinical data that was already on that portal. So a VA user can go onto VA's website, log into the portal, click a button, and they get this ASCII text dump, of their data. It's not that advanced. If you guys know ASCII files, it's kind of just a text blob, but it's been really powerful. Even this simple level of access has attracted 1 million vets and their families clicking on the button and downloading their data over the past couple of years. And since then, some really important major payers and providers have sort of joined the Blue Button cause and added the functionality to their portal. So it's sort of become this sort of consistent standard for giving consumers access to their data. CMS, DoD, Relay Health, Aetna, and United are some of these really large data holders. So through the Automate Blue Button initiative, we're hoping that the Blue Button will stand for something more. It will give individuals a way to meaningfully connect their data with the apps and services of their choice. In August of 2012, we launched a standards and interoperability initiative at ONC to work on more advanced implementation guidance to be associated with the Blue Button. It'll follow Meaningful Use Stage 2, so building off of the requirements to be able to publish a continuity of care document in the consolidated CDA standard and the ability to send electronic health data via direct. And so for data holders that implement this new implementation guide, it'll give the app developers a way to access that data on behalf of a patient. I'm going to turn it over. Oh wait, I have one more. Oh yeah, right. So and on the S9 initiative, I just want to give a shout out to the really incredible team we've had working with us on this. We have 4 work groups. We meet once a week with each of the work groups. And we've had most of the major EHR vendors, most of the major payers involved in that initiative, and a lot of the third-party apps and services that stand to really benefit from this. So I think Ryan will give a plug at the end, but we really welcome you all to join.
Awesome. Thanks, Pierce. So what's exciting about Blue Button is that it has been downloaded 1 million times, right, in its simple text form. What gets exciting for, I think, all the participants in the Blue Button work groups, and Pierce and I and everyone up here, is that there's a lot more that it can do, and there's a lot more that we can do to make it even more successful. And so when we look at what's next, there are 3 really big things. The first part is liberation, right? Getting that data out from these silos, right? You know, if you see multiple providers or multiple specialists, that data is in silos, and it's very important for you and I as consumers, as patients, to get that. And the vehicle to do that is going to be Meaningful Use too. The next big thing we're looking for is structure. The Blue Button file, you know, that exists before, you can print it, take it to another doctor, but when it says penicillin, it could be misspelled. It could be represented in different ways. When you put structure to it, it actually helps a lot of developers along the way. And then the last bit is automation, right? Not just having to download it every time, but being able to automate that process. And I'll talk about each more in a second. So structure is incredibly important for the industry as a whole. And when I say industry, I mean a lot of the players here, right? I mean, if you're starting a new company, or if you're starting a company in healthcare, it'd be important if every single provider talked in the same language. And so what we're doing here with the structure of the new Blue Button data file is we're relying on a standard called the consolidated CDA to define what's in your health record. So like when I was giving that penicillin example, it isn't just penicillin, but it's penicillin, the RX norm code, the dosage, and every little bit of information that you need to create a really meaningful app. And consistency is important too, because you know there are a lot of hospitals, there are a lot of EMR providers, there's a lot of places where this data can come from. It's very important for all of us to speak that same language. And so the one thing we're striving for is, as a developer of mobile health apps or web health apps or software-based health apps, you can start to expect a consistent standard. And so what I'm showing here is actually a little bit, a kind of a sneak peek of the Blue Button implementation guide that those 68 partners that we've been working with are putting together. So like Pierce said, we meet 4 times a week for about 4 hours total to put together something like this. And this section in particular is talking about the content format. And so afterwards, I think I'll find a way to get this link to everyone. We're going to be publishing it and sharing it more next week at our ONC annual meeting. But this is a place for you as a developer to find out what a Blue Button content is going to look like, what a consolidated CDA is. It's going to give you all the resources you need to do that. The next little bit is the importance of automation. So we all know from the days of banking where you could download your transactions and upload it to Quicken, and you'd have to keep doing it over and over again. And for the incentivized few, like business owners, we would do that. But as the general consumer audience, something like Mint had to come along to automate that. And so we're trying to learn from those lessons in this other part of Blue Button to kind of make it set it and forget it, like we like to say. So a consumer can set this up once, point it to your application, and now forever your application will always get a always up-to-date bit of information. And what's really neat about that is I think we all know there's a sense of fatigue when you build these mobile apps that people have to keep checking into every single day after every encounter. If that could just be happening behind the scenes, I imagine you could see your application being more successful, more used, and even more meaningful. And so what we have here is a sneak peek at the two different sections, which shows how providers are going to be sending and transmitting that information, and you as a application developer are going to be receiving it. And, you know, it's taken us about 5 or 6 weeks of really honing in this documentation because we're working to make sure that this is incredibly secure, incredibly private, incredibly trusted, because remember, it's someone's health information. So both the data holder and the receiver need to be playing by a certain set of rules. And so this documentation is going to cover and talk a lot about that. And I think our team here is going to spend a lot of time in the next few months making sure we do as much as we can to educate developers, consumers, data holders, and everyone on this new change. And so the takeaway for Blue Button right now is if the whole concept of structure and you're wanting to build on this, the two things to look at are learn about the consolidated CDA. That's where the industry is going. That is the kind of format that's going to be spit out, so it's important to learn that. And also learn about the sections that are going to be required in meaningful use too. These are everything from allergies to medications to problem lists. There's a lot of information in there. And so as an application developer or as a company that's building these tools, those are the things that you can expect. If the automation bit is something that kind of stood out in your head, like Pierce said, come help, come join, be a part of this S&I initiative that's defining Blue Button. You'll learn a lot about the push efforts that we're doing as well as the pull efforts. They both are trying to accomplish two different scenarios, but they're very important, and we need your help to define those because like Lygia said in the beginning, this isn't us creating these things. It's actually the community as a whole having a space to do that. Learn about Direct, the Direct project in specific, because that's the means that we're going to be using to send this information securely. And also, if things like OAuth and REST excite you, the pull work group is looking into that extensively. So that's Blue Button. We're going to be up here afterwards to talk a lot more about it, but I also wanted to share one little bit of a challenge that we're doing. So this is almost like transition, thinking about Blue Button, now jumping back, is that this screenshot that you see here is what a Blue Button file looks like today. I think when we all came in and looked at it, we said, you know, I'm a designer by my background, and I said, you know what, that could be a lot better. Right? It could be a lot better. And you know, we were talking about some of the mechanisms that the federal government has to improve these. And you know, we could have gone behind a closed door and figured out how to make it better. But we said, you know what, there are an amazing group of designers out there in the healthcare world and outside that could probably do a better job than we could. And so not like a little less than 4 weeks ago, we put out the call to say, hey, these are the fields, these are the things that our industry is going to be outputting. Can you help us a little bit? I think, you know, Pierce and I had some conversations in Henry, and we thought maybe like 30, you know, we get 30 results. Like, I think that'd be pretty good. We could keep moving forward. We were blown away. In 4 weeks, we received over 230 submissions that looked at this ugly little thing and made it into something even more meaningful. And so I'm going to share a few of the entries. We received these on Sunday. So this is the first time anyone is seeing them, and we can't wait to show you them all later this month and continue to do more with it. But this is an example of what one designer did to make it easier to look and parse this information. And so as we saw some of these results, some of these designers, I mean, these are folks that came, oops, come on, click, there we go. Folks took a whole new look at how information can be presented. This is the same information that's going to be in a consolidated CDA or a Blue Button file, and they show it like this. Right? Like, these are really, really neat ways for a normal human being to be able to process this information to make it more useful for them and to be more in control of their health. I thought this was neat. This was a little snippet from an incredibly long PDF of different examples, but this person had this great little idea to put maybe a dotted line at the top so you could tear off the top of your printed health record so when you give it to someone, they don't have your personal health identifiers. And this is the last one I'm going to share. Some entrants went really above and beyond, right? We asked for just a reimagining of the printed record, but they said, well, you know, print is great, but what about all the other things that we carry with us? And so we can't wait to show this off to you. And we are so excited that all 230 of those submissions, those designers did this out of, well, one, there was a challenge prize, but out of the kindness of their heart, it is in the open source community. It is for the Creative Commons to use. So it's a great showing of what creative talent can do when you focus people on an awesome problem. I think it's, oops, my time is almost up. But if you want to follow more of this Health Design Challenge, just go to healthdesignchallenge.com and you can follow things there, and we'll be sending more updates. So I'm going to hand it over to Damon, who's going to talk a little more about consumer e-health.
So again, my name is Damon Davis, and one of the things that I do at ONC is work on our Blue Button Pledge community. So to backtrack for just a hot second here, you've heard us talk a lot about Blue Button and its beginnings at the VA, but it's important to recognize that the VA said, we've done a lot with this, but you, HHS ONC, really have the mantle of sort of broader mass population e-health, and we really think that this is an opportunity for you all to move forward and carry Blue Button to a much larger and grander scale. 1 million downloads is really incredible, but there's 300 million people in the United States. So there's clearly a big opportunity for us to sort of advance the ability for people to get access to their personal health data. So one of the things that we did back in September, we had a Consumer Health IT Summit at the department, and it was there that we launched the Blue Button Pledge community. We evolved our previous Consumer eHealth Pledge community to actually incorporate the fact that Blue Button is what we consider to be a recognizable brand that all of you different innovators and various stakeholders, clinicians, etc., can utilize as a way for an individual, like, say, my aunt in Kansas City, Missouri, to quickly recognize when they come to your app or your website or your portal that this is the place where they can download their data. And so we've got over 450 organizations now that have said, we are interested in supporting the Blue Button Pledge for personal health information access. And so you'll see an incredible array of names on the website there, but the names are actually broken down into two separate groups. There's our data holders and our non-data holders. The data holders are the organizations that actually, quite literally, when you walk into their office, you have now contributed to your own data record there at their site, but that's your data, and you have a right to it as a consumer, patient, individual, caregiver, what have you. So the data holders we're working closely with to try to get them to liberate the data. We're trying to help them to understand what the opportunities are through things like Abby to make it so much easier for them to liberate their data so they can now really truly get to the levels of patient engagement that we're all hoping that the healthcare system will reach. On the opposing side, there are the non-data holders. They don't actually have the data, but they have a tremendous megaphone and a true opportunity to reach their constituent bodies and let them know you have a right to access your personal health data, and here are the ways that you could get it. And so we're working with those two different individual organization types to help them to get the message out about Blue Button writ large across the United States. But on a different note, one of the things that we're trying to focus on is, as Lygia said, the action piece, the development of tools that will help people to understand what their health data means. A lot of you in this room are clinically trained. I personally am not. So when my doctor says to me that one of my numbers looks a certain kind of way, your hemoglobin A1C is this, I'm like, great, but what does that mean to me when I walk out of your office and I no longer remember the context that you gave me there? It would be great if I could have my personal health data and in some way refer back to it at a later time. And so just to sort of backtrack for a quick second, in 2009, the President started an initiative where he allowed every department across the government, and I'm saying not just HHS, this is DOD, VA, education, you name it, they can do it. They can all set up a challenge where, much the same as what Ryan has already pointed out, we can crowdsource solutions to things that we see as problems that we want to just go ahead and fix now. And we recognize that we don't have the best way to do it. You probably do. So we look for you for those solutions. So we launched the Blue Button Health Data Mashup Challenge. And we really got some exciting entries in it. And basically the Blue Button Health Data Mashup Challenge was intended to help an individual to quite literally mash up their own personal health data with publicly available sources of data. The idea is that when you walk out of a clinical visit or wherever you're getting your personal health data from, you need to be able to refer back to it and understand again what it means. What was it that the doctor said or whomever at the time that you had that visit? And so our winners from that challenge were Humetrics with the Blue Button, Intelligent Decisions with ID Blue Button, and a group called Get Real Health with Instant PHR. And I'm just going to walk you through those three things very quickly. The first one, Blue Button, they share full Blue Button medical history with providers at the point of care as well as with you as an individual. So what you can see on this slide is I can have my Blue Button data on my personal handheld, and they mash up the data quite literally with gangs and gangs of publicly available health sources. You can find a lot of health data sources on healthdata.gov. There are a tremendous amount of APIs there, but they also use NLM data, and just you name it, they've got all kinds of different types of data. And so an interesting thing that you can do with this particular app is, say for example, I've started a med, I no longer feel very good when I take that med. I don't want to take that medication anymore. But if I have a way to sort of quickly report back to my provider or my clinician that I'm no longer taking that medication, I can basically click it off on that personal app, and my provider will get that on their version of the app. And so you can see how quickly patient engagement is promoted by virtue of the fact that these two, the consumer and the provider, are on the same platform. I'm not doing it justice by describing it here, but I wanted to make sure to highlight it. That was our winner of the Blue Button Mashup Challenge. This one here, ID Blue Button, was really interesting in that it allows you to download your Blue Button data, as all of these do. And then in this particular one, you can actually go through and see your data on a timeline, which is incredibly valuable. Sometimes you're supposed to take data for an extended period of time. Sometimes it's just for a short period of time. And sometimes it's hard to sort of realize, when did I start taking this medication and when did I start taking that one, and was there an overlap? And so this one I thought was incredibly interesting in terms of just its ability to help you to visualize basically your own context of your health information from Blue Button sources. Finally, Instant PHR from Get Real Health. They basically allow you to bring in your health data and contextualize it with other things that you've put into your PHR. So there's a lot of comparative analysis that they will allow you to do. So again, we're trying to motivate people towards taking action with their health data, but we also want to help people to have the tools to do that. And so that's part of what we're trying to catalyze out of our office. I'm going to turn it over to Henry now to talk a little bit more about sort of development of the organizations that have the data into ones that are really embracing liberating it for our own uses.
All right, here we go. If I can find the button. It's a green button. I don't recognize it. Here we go. Hi, I'm Henry Way. I'm a doctor, a computer geek, and an insurance guy. And let me tell you about some other stuff we've been working on. So that pledge community that Damon mentioned, that bottom left thing says pharmacies, but hopefully that icon makes sense to you. These are the major data suppliers, and we've been going and reaching out individually. One of the most common questions out there is, how do I get this graphic asset? How do I actually brand my download as Blue Button? It's simple now. Go to healthit.gov/Blue Button. The graphic assets are there for download, for resolution. The usage guidelines, they're pretty straightforward. Everything from hardcore clinical data to even financial health data, that's Blue Button data. And if you're offering it as a download to a consumer today, just get that brand up there. It's like a recycling symbol or a hospital symbol you see on the highway. Make sure that's there so that the consumer instantly recognizes that they can download their data. And we're reaching out not only to the classic thoughts that you think of as providers, insurance, and pharmacy benefits managers, but also employers, the platform vendors. We've thought about the EMR vendors, but also in the heavy-duty insurance world, there are a lot of platforms that can offer this and making sure that they're aware of this need as well. The big picture, in case Ryan, for example, hasn't hammered it home enough, and apologies for my font sizes here, the right-hand side really matters. We want to see more apps and services. We want to see more caregivers involved. And one of the only ways to help that happen is to get the data out. Today, when your doctor talks to you in the office, that's maybe, I'm going to get technical here, about a 200-300 baud transaction. They're trying to upload to you a tremendous amount of information in a very short amount of time. They have to get that out to you in a little better way, in a large bandwidth, and what better way than to in some kind of standardized file. So Blue Button is key to that and getting it to all of these downstream uses. Part of this entire community building is online. What we've seeded here, and you can just remember that top URL, about.me/Blue Button, is to make sure that all the constituents have a place to gather and discuss what they're trying to do. I'm actually going to skip down to the fourth thing there. GitHub is the home to a lot of the work, for instance, the design challenge work that Ryan mentioned, as well as implementation guides. But we've set up these different things. They're not really federally run. They're organic. They're intended to be way stations for folks to go in and discuss their needs and also solutions and learn from each other as to how to use and do Blue Button. So about.me/Blue Button will take you to all of these. The big thing here is that this is a piñata problem. There's nothing wrong with piñatas. I love piñatas. I love when stuff comes up, but everything we've been talking about strives to get at a standard that you know that there's this, not just candy corn in there, but the candy I love the most. This is the data I want. This is what I need as a developer that I can expect that's going to come flying out of this piñata straight into my app. And as mobile app developers are probably littered throughout the audience, you should care about this because of that piñata problem. So one example of this that we've been working on, and this is just to highlight some more activity in the Automate Blue Button community, there's a lot of text on the page. Suffice to say that the left-hand side is what you should care about. You know that thing that says this is not a bill? That constitutes the basis, the information in there of a lot of that footprint of about 80 million Americans right now that have Blue Button access through their health insurers. We'd like to make that a little more usable to developers in a way that they can expect what's coming down the line to enable a number of services that are already available today. It's just that you have to be a big employer and insurance company to actually access those. But there are a number of things that are possible, even with that admittedly not as nice as EMR data, but it's still clinical, and there's a lot of financial data in there as well to help folks enhance their financial literacy, because that's an important part of health as well. One other thing that we're doing is also promoting provider education. Now, if you go into your doctor's office today, they might not know what Blue Button is. Markle survey in 2010 actually shows that they actually care about it. They just haven't heard this name enough. So what we're doing right now, initially with the Department of Veterans Affairs, is enabling training for the full population of physicians in the VA and also other healthcare providers to learn what Blue Button is, and also something else called Open Notes, which is coming to the VA. Over 65% of all U.S. physicians have actually had VA training, so this is a common pathway that many of our physician population goes through, and the idea is to then expand this more broadly to the rest of the physician community, but we're starting here first. So I'll hand it off to Aaron now. Thanks.
All right, so that's a tough act to follow, but I'll do my best. So I'm Erin Petter-Seminario, and as I mentioned, I'm a policy analyst in the Office of Consumer Health at ONC. So far we've talked a lot about our efforts in two of the three areas of our strategy. So we've talked a lot about how we're making it easier for patients to get electronic access to their information, to exercise that legal right that they have to get that information, and about how we're creating an ecosystem that supports the development of tools and new ways consumers can interact with that information. Next, I'm going to talk about what we're doing to shift traditional patient and provider roles. This is some of our most difficult yet important work, and it encompasses efforts to promote Blue Button, but kind of more broadly than that. So the traditional mindsets of patients and providers, there's traditionally, patients sort of passive recipients of information a lot of times, and we're working really hard to try to kind of change that paradigm. We want consumers to think and act as partners in their health with their providers. And we recognize that there's a lot of barriers to that becoming a reality. So patients might worry that by asking a lot of questions, they might be viewed as difficult by their providers. They might be kind of reluctant to ask for their information. On the flip side, doctors might be worried or concerned that patients asking lots of questions or having a lot of access to more information is going to cause additional time that they need to spend with those patients to explain that information, and so on. So we recognize that in order to have a true shift, it requires a shift on both parties, the provider and the patient. So to bring about this shift, we're doing a number of different things. Some of our work is focused on direct-to-consumer kind of outreach and education. Some of it is through trusted organizations and advisors. So consumers trust healthcare professionals above all other professionals. And so this is a really important avenue through which we can get these important messages out about the power of having information, about the power of using that information, and about being more engaged in health more generally. We're developing a lot of materials for providers to use, and part of those materials are meant specifically to assist providers in meeting the threshold requirements that Lygia mentioned. So in stage 2 meaningful use, providers are going to have to use secure messaging with 5% of patients. They're going to have to not only offer it to patients, but 5% of patients are going to have to actually use that technology. Similarly, for view, download, and transmit, there's a 5% requirement as well. So we're trying to equip providers with resources that they can use to have these important conversations with their patients. We also have a tremendous resource called healthit.gov, and this is a one-stop shop for patients and families to get information about health IT. What are the benefits, kind of what are some of the tools and technologies that you can leverage today? What are your rights? How can you have a conversation about this with your provider? And this website leverages one of the oldest forms of communication, storytelling. So what you'll find on this site is a lot of great information and a lot of really powerful personal stories from people like ePatient Dave, who has a great TED Talk. If you haven't heard it yet, I would suggest you check it out. It's really compelling. And Regina Holiday and others who talk about the real difference that having information and using technology has made in their lives. We also have on our site a toolkit for organizations to use and also communicating some of these messages to their members. So there's some brochures and other literature that you can access through that site. And we're always looking for input from you in terms of what else you might need to help propagate some of these messages. One thing that we did the past year to get some more personal stories from the public is we worked to crowdsource the creativity of ordinary Americans, kind of like what Ryan was talking about, crowdsourcing, creativity of designers out there. We put together a series of video contests that ran throughout the year to ask ordinary Americans to share with us their stories about how they've leveraged technology to improve their lives. The first one of these we did was the Healthy New Year contest, where people said, here's my resolution and here's how I'm going to leverage some type of technology to achieve that. We also ran one called What's in Your Record, where we asked people to go and ask for their information and tell us sort of what they found when they took a peek inside. That one was pretty interesting. And there's a lot of great stories that have come out of these video contests. I would be remiss if I didn't mention there's kind of one final opportunity if any of you are interested. I'm sure most of you have a mobile device with some sort of webcam on them if you're at this conference. So there's a couple days left to participate in the last two of these contests, the Family Caregivers Video Challenge and the Cancer Care Video Challenge. There's more information available on challenge.gov about both of these contests. And there's, in case you needed added incentive, there's about $8,000 worth of prize money available to the winners. So finally, I want to mention that we have one tool in particular that we are very proud of that we are using to educate and engage the American public about the importance of leveraging health IT. And that's our Health IT animated video, which is available on our website at healthit.gov/4U video. We worked with an advisory panel of kind of a diverse group of stakeholders to develop this video over the past 9 months. And we sort of created this in recognition of the fact that most people are not aware of the role technology can play. So we wanted something to be fun and engaging, kind of a start to a conversation about the difference this can make in people's lives. So we encourage you to check out the video. If you have websites of your own and you're trying to communicate to the public about the benefits of health IT, feel free to embed it on your site. It is on YouTube, and we encourage you to use it. So here's just some basic contact information for all of us and some of our Twitter handles. And then finally, just a couple of different ways that you can stay connected to some of the work that we're doing at ONC. I want to mention that in February, we're going to be releasing our consumer engagement strategy for public comment. We're going to be putting this on a very interactive site for 45 days so that you can go in and kind of read a little bit more about what our strategy is and what specifically we're doing to execute against that strategy and kind of what we've set out to accomplish over the next couple of years. So be on the lookout. The best way to find out about that when it goes live is to sign up through ONC for our listserv messages or to follow one of us on Twitter. I think that's it.
Cool.
All right. Thank you. So that's a lot of information, and now we want to hear from you. I do want to point out that there are a couple of ONCers, other ONCers in the audience. Give a quick wave, maybe. We've got Jody Daniel over here, who directs our Office of Policy and Planning. Okay, maybe it's just one. So the other thing, though, that I do want to point out is that in order to continue this conversation after this event, later this afternoon, we will be having a happy hour at 6:30 at the Cadillac Ranch, which is at 186 Fleet Street. So if you have more questions or just want to hang out and have a beer, come on over. So yes, please ask questions and let us know who you are and what organization you may be affiliated with.
I'm Stuart Nelson. I'm a recently retired federal employee, now working with Apollon. I have a couple of comments. First of all, one is that increasingly it seems important. I mean, having just retired from federal service, I've found out that changing your insurance information is not easy.
Yeah.
It would be really nice if there were a blue button app that actually allowed consumers to put in their own information. You know, this is, I think, a very important thing that, you know, in all the blue button, it's all kind of download. You need to have some upload, too. Second comment, as a former federal employee who built websites, you know, one of the concerns that I always had, even before there was such a thing, was Section 508 compliance. And Section 508 compliance, I think, is really hard in web service, in mobile applications. But I think that you need to pay a lot of attention to that, about making it accessible for people with disabilities. I mean, I joked when I had my iPad that it was an iPhone for adults, because I could actually see what was on the screen. But I think that those kinds of issues are very important for adults. And as I get older, I started to realize it myself. The last thing is, in 20 years of medical practice, where I really was trying to be a patient advocate and to work with patients and get them engaged, I found that a lot of patients, particularly older patients, did not want necessarily to be engaged. They don't want somebody to come and say, well, you could do this, or you could do that, or you could do the other thing. Now, what do you want to do? They want somebody who can guide them. And in searching for trying to get patient engagement, I think you need to be aware that sometimes patients are not the best decision makers, and they really do need that help and guidance.
Thank you. Those are all thoughtful comments. I don't know if anyone wanted to. They're excellent. And
I just want to say one quick thing with regard to, those were all really good points. With regard to the blue button upload sort of two-way communications piece, one of the slides that Lygia presented earlier was the fact that there's currently a request for comment period sort of open, and there may be room for you to make a comment on that. So again, encouraging everybody in the room, if you've got opinions on these kinds of things, certainly look to this request for comment period as your opportunity to express your opinions on these various issues.
I can't resist also commenting on the third comment, which was about essentially the point that patients are very different and engagement means different things to different people. And some people, like people who participate in the quantified self movement, are out there tracking, you know, every little detail of like what they ate for lunch and what the implications are, for example. For other people, that's not a model that's appealing, and they would prefer that information be made available and shared with them in a different way, and that they not take on as active a role. However, I believe that with interfaces that are more intuitive and the promise of more of a direct connection to your future life, like the kind of thing Ryan was talking about, it could be more appealing even for, you know, somebody like an elderly patient who doesn't want to get into all the data. If they can look at a simple picture and go, if I do this, this is how I'm going to be walking in 6 months. If I do that, this is what my life looks like. That's more compelling, I think. So I'm hoping these tools will drive engagement among a broad spectrum of patients, also realizing that there's no one size fits all.
And if we address two of the three, I'll take the last one. On 508 compliance, a big part of Blue Button has always been about as accessible and as possible, right? The first version was simple text, which is 508 compliant. When we put out the request for these designers to think about it, there were 3 categories that were all focused around accessibility to varied population, varied languages, eyesight, and so we can't wait to share some of these designs with you because I think you'll be pleasantly surprised. These designers have heard that request. We made sure they knew about it, and so I hope that issue is addressed in the things that we see.
Yes, gentleman in the back.
Hi, I'm James Gaston with HIMSS Analytics. How are you all today? Very excited about the progress and the excitement around Blue Button. But I want to touch on a couple things, and I don't want to make this my platform, but Damon, you mentioned, you know, people should request their healthcare data. It's their data. And I think that's incorrect. Maybe you correct me if I'm wrong. We as patients in the U.S., we don't own our data. The insurance plans owns the insurance data. The providers own the data they collect. We have the right to request it, to have them give it to us or access it. We have the right to restrict how they use it with disclosures and so forth. But I don't think we own it. So if you could maybe clarify there, maybe that plays into Blue Button a little bit. And then the second part I wanted to bring up, or see if you all could address, is, you know, why is Blue Button optional? We have HIPAA mandates that mandate claims transaction standards, ANSI standards, eligibility standards, enrollment standard transactions, all of that. Yet when I go to how many ever number of providers that I might see, and they're mandated to give me back my information in electronic format if I request it, they can give me a PDF, they can give me an ASCII that doesn't match the Blue Button standard. They can put it on a floppy disk, 3.5-inch floppy, and say good luck. So why is this an option when it's one of the key things about beginning to assimilate and share healthcare information? Thank you.
Thanks for those questions. So I'm going to start off with the first piece. I say that from the context of the simple fact that if you didn't walk into the clinician's office, they don't have your data, right? You are walking around with your data on a regular basis. You're the one who knows how you feel. You're the one who has the blood sugar levels and all of these things. So quite simply, it is your data. The fact that they are the person that you go to seek care means that they have it. They're your data holder, which is how we term it in the Blue Button Pledge community. The Office of Civil Rights at the department feels very, very strongly that, in fact, it is your data. And they have published a letter where the director of the office has quite simply said, you have a right to access your data. And that is intended to help empower all of the consumers, patients, caregivers. You call them what you want, whatever category you fit into. It's intended to empower every single one of us to say, you know what? I really should be asking for my data. I don't remember what we said about me when I was in the office, right? And so I just want to sort of help everybody to think a little bit differently about when we think of ourselves versus the clinical environment, that it really should be us and the clinical environment. We should be in this together, and I don't want us to create any sort of adversarial language when in fact the true idea is you have a right to your data, you should try to go get it, and you should feel empowered to do so. You should really feel empowered to have a partnership with your clinician towards your own better health. So I don't mean to put any kind of adversarial name or verbiage out there. I think I've sort of made clear what it was that I was trying to say, and I encourage every one of you to think about that OCR letter and how you might use it to empower the people that you are in fact serving with your apps and tools and innovation, stakeholder development, etc.
And OCRs also release guidance on exactly what a designated record set is, and so what data you have a right to, both on the clinical side and on the financial claims side. And then to the other point about why these are not, why Blue Button's not required, I think the standards need to get there first. So we need to have implementation guidance to require before we can require it, and so that's what we're working on now.
So so the requirement will be for VDT being able to view in a certain way, download in a certain way, and transmit. And so the Blue Button implementation guide and the work that the community has been doing is supposed to be the kind of that driver for consistency. Because right now, if you look at the rules, or if you look in the past, if you saw Blue Button, great idea, okay, I'll just take the concept and implement, we're all going to do it in our own different little way. And so the hope for all the work, and I mean, I think Pierce and I can't stop thanking the community enough, is because, they've dedicated their time to make sure we all get on the same page. And so this guide, per se, is a great thing to look at because it's almost going to be the way we all speak the same language. And there's a lot of room in the guide to be very innovative and do your own thing, but for certain things like format consistency, transport consistency, that's why it's there.
I can't resist chiming in on the question about ownership of data. As these guys have underscored, the HIPAA privacy rule gives you a right to access your data, period. However, I actually think the question of ownership is not really the right question in a digital world. And to sort of quote or refer to the Markle Foundation and some work it's done in this area, in a digital world, you make copies of information. And so it's not like a physical thing, I own it. You can have a copy of it, and your provider can have a copy of it, and your insurer can have a copy of it, and there are rights about how it can be used and not used. But I'm not sure own is quite the right concept in a digital world. Yes, sir.
Chris Bickford, a general practice primary care doctor, 30 years in San Diego. And I could probably spend an hour talking here about the topics you've brought up and discussed, but
happy hour.
I could go straight to the direct questions. They're a little bit off topic, but I've had a few iPhone 5 patients in my office, and we established a FaceTime consultation call format, proof of concept. And I'd be interested to know, I talked to my insurance carrier, malpractice carrier, said absolutely you are not covered. We don't have any people on our plans that are covered for that kind of video calling. Number two question and issue is, are you aware of any federal government rules with regard to payment for video consultation between doctor and patient? And I would just like to say on that data ownership one, it's very clear from the discussion today. The data is so complex that there is issues with regard to when a patient says they have dreams, they're talking to God and they'd like to kill their mother. Your diagnosis as to what that symptom or subjective complaints amounts to in the way of a diagnosis is a piece of data that's incredibly sensitive, prejudicial, and it's a data element that I don't think anybody has ever thought about when they're discussing this, who owns it. Be interested in the comments.
Anyone jumping out of their seat on this one?
Go for it.
So the first question was on malpractice coverage for video interactions, and the second one was related to payment for that. So, it's an excellent question, something that we haven't considered as the scope for Blue Button. The best, and this is really a personal perspective that I can offer, is that the reimbursement environment is intentionally changing to reimburse for value. And so while there might be a code right now, there actually is, for a video encounter, and while that reimbursement is zero, if you look at accountable care organizations and other entities that become risk-bearing entities, if video encounters wind up being a more scalable, cheaper way of reducing readmission or other risk, then you have your reimbursement mechanism there. It's a bit of a longer story. You can't bill for it as a code, but if it makes sense, it will become adopted.
And as far as HIPAA compliance with FaceTime versus Skype,
I am not personally familiar with the FaceTime intricacies of the protocols. I do know that there have been analyses by third parties on FaceTime, on iMessage, and other of Apple. So we've actually engaged them in conversation. Be happy to look into that for you.
there's a claim that Skype is HIPAA compliant with its lockdown.
Yeah, one thing, and this is probably for a different conversation, is that we are working with the Office of Civil Rights to clarify and give guidance to developers on certain aspects of privacy and security, because HIPAA actually only covers half of the universe here. There's other things when you are not a covered entity that you still have to follow. So please, for the devs in the audience, check out GitHub, keep your eyes peeled for that.
I think it's also worth mentioning, I don't know that this particular issue will be addressed at all, but there is another session between 5 and 6:15 today at which our Deputy National Coordinator, David Muntz, will be speaking along with panelists from other federal agencies about policy issues related to mHealth. So just in case you want more around that vein, I think FDA and FCC are represented as well as ONC. So, next question.
Basically, I'd like to congratulate everybody in this panel for making Blue Button a reality in our country, and I'm speaking from a caregiver perspective on how these programs will help, especially the elderly population and caregivers, and how you have really put out there innovators like the iBlue Button to automate the Blue Button program. I remember 4 years ago, I went to my mom's cardiology, and I asked for the electronic health record, or for her medical record, and they gave me a memory stick, and they charged me $170 for that. So from 4 years ago to now, that I can download her record on my phone and be able to take it to all her specialists, and they're all on the same page in terms of what needs to be done to her, translate very simply in the ability to reduce costs and to keep her here with me. I give you a very a small story that maybe we can carry in Cadillac happy hour, but my mother fell in a grocery store. She broke her arm. I was with her. I had the Blue Button on my phone. I went to the emergency room, and I was able to give all the doctors in the emergency room. She's a cardiac person. She has a pacemaker. She has high blood pressure, high cholesterol, and immediately they were able to see all her list of medication. And they, in the moment, they say, we cannot do this, we cannot do that, we cannot give her this pain pill or that pain pill. The result of the story, after taking the iBlue Button to all the medical community that she had to see, was that she was healed in 4 weeks with just therapy. And that is what the iBlue Button initiative is all about. I encourage everybody here to take one step further and help this team move forward. Thank you very much.
Thank you.
So just quickly, do you actually have, first of all, I'm glad your mom is okay, based on what you've said. Do you have the iBlue Button app?
Yes.
Gotcha. Okay. You said, gotcha. Very good.
Well,
Thank
we can't
you.
get enough of stories like that. So
Yeah,
keep
so
them coming.
I'll tell you real quick, the national coordinator, Farzad Mostashari, actually has a really interesting Blue Button story, too. He was caring for his father recently, and he had the same thing happen. You know, the national coordinator, who is coordinating all of these things, quite literally turned into caregiver, you know, very immediately, and was able to go to mymedicare.gov, download the Blue Button data for his own father, and was able to care for him with real-time information that the provider on scene at the time of the need for care would not have had he not had the information in hand. So those kind of stories are really, really cool to hear, because that's exactly the kind of thing that we're striving for. And, you know, there's so much more to come.
As Aaron mentioned, there is still a video challenge open for caregivers that relates to this theme, and you have how many more days to enter it, Aaron? Just a simple little film on your iPhone. Just saying. I'm not sure. Good question. All right. Who's up next?
My name is Manu Uppal. I help out health insurance companies, basically on the IT side. That's what our company does. The question I have is, again, going back about who owns the data. If someone writes an app, and let's say I put a blue button for my parents, and they go and download an app, and that app, as a part of the, nobody reads the policies and procedures, and they go and hit yes. Now what happens is that the data that's coming down to the device now can be accessed by a third party. They have controls over the third party, and of course I'll go into the NPRM for the stage 3 and comment about what happens if that third party then goes ahead and writes something in your medical record by sending it up. Example could be, it could be anybody for fitness, it could be anything like that where they have an app where you actually share data. The other thing that you mentioned was the EOBs, the ones that say that this is not your bill. Somebody could write an application that could say, hey guys, we'll give you $100 if you go ahead and allow us to get access to your EOB data. I mean, keep in mind, I'm just looking at they can have different ways of doing it. But what that would happen is then I would know, or the company would know, every doctor, how much they charge, how much they go ahead and insurance company pays on that policy, and how much is the deductible of the actual individual patient. So the question about the data rights, especially with the blue button now and with the EOB data being downloaded, because it can be accessed so easily and it can be mined so easily. So my questions are, can third parties go ahead and get access to the data, including downloading as well as eventually in stage 3 uploading? And the third thing is, can they go ahead and use that data for other things? It could be for good reasons. It doesn't have to be for always bad reasons. It could be just going ahead and listing all the providers and how much they charge. So I know that if I go to this doctor, he's going to charge me $100, whereas the next person, they're charging him $75, for example. So I just want to know a little bit more about the data rights. That's it.
Yeah. So the question is, let me just try and clarify the question. Who owns the data if it can be accessed by a third party and shared with others downstream?
Can it be accessed by third party?
Can it be shared? And the use model you gave was a company that could help give visibility into how much doctors charge?
Yes, so for example, let's say that everybody signs up for an app.
Well, let me interrupt you. How many people would like an app to figure out how much doctors charge? Just raise your hand. Okay, ownership is a great question. You just saw consumer demand. So ownership, yeah, it's definitely an issue, and particularly with network contracting discounts. But you just saw a room full of consumers express a demand. How many of you would pay 99 cents on the App Store for that app? Right? Okay, so I just created an accessible market here of about $10 million just with one app idea. Ownership, market demand. There's certainly legitimate concern on the part of those that would construe that information to be proprietary, but on the other, there's tremendous value to be unlocked from liberating that data. So I don't purport to have the answer to who owns and who has rights over that sensitive discounting information, but that's not the end game. The end game is actually to deliver more value.
Did you want to comment on that or add a... Oh, I think the lady at the microphone was up next.
Yeah,
Sorry,
my
one sec.
name is Dr. Martha Rodriguez. I'm an internist in Boynton Beach, Florida, and I have a large population of patients both in managed care and fee-for-service settings. I'm also part owner and chairman of an ACO, so I love the concept that you guys are bringing. I really congratulate you on your knowledge. It's brilliant. It's way overdue that clinical and IT settings get together so that we can move forward faster. Now, I've been electronic for about 8 years in my office, and I'm struggling through the meaningful use process. It is not an easy process. This is not about us, it's about the employees, it's about the patients. It's a huge project from our perspective. But I think it's worth it. But during the time that I've done electronic medical records, I've taken a great amount of effort to customize it, because electronic medical records, as you guys know, are terrible. They really are. So I actually, in spite of being in solo practice, have a full-time IT person that I employ who's brilliant and has helped me through the years to be able to accomplish this goal. Part of what I've done is And I've had this for about 5 to 6 years. When the patients leave my office, I give them a summary of what has happened, including their medication list, including every test they've had in the last 2 years, the 2 words to describe the results, their who to contact in my office, all the things I'm meaning for use. I've done them for about 5 years. Now, through that time, though, I've run into a persistent challenge. When a patient gets access to the complete chart, to the complete, let's say their active problem, which I think you said is part of meaningful use part 2, that they will be able to access their active problems. Now, I went to school for about, I don't know, a lot of years. And part of that was because I needed to learn a language. Besides learning English, which I didn't know, I'm still struggling with that, but I needed to learn medical language. It's something that I didn't know. It's the same concept when I got involved with this IT setting. If you tell me what a CCR or HT7, I still don't know these terms, they're foreign to me. That's not my language. So here comes a 75, 80-year-old patient, gets a copy of their records. Now, you guys know that we are forced to code every page, every visit with diagnosis codes that have names. That's a language. Some of which is COPD, some of which is hypertension with renal failure stage 2, which we know, physicians know that that's not really renal failure, but that's how the government has asked us to name these codes.
Right.
So they leave and come back freaking out with these terms that they don't understand because they don't. I want your feedback on how do you expect us to deal with that?
So,
Okay. Damon, do you want to take a first cut at that?
so I'm going to take a first cut. That's a very, very good point. You touched on a whole lot of things there. You know, linguistic challenges, be they English versus another language, or quite literally clinical training versus not, which is one of my challenges. And so that's one of the things that we look to the innovator developer community to assist us with is how can we take this complex data that an individual might get out of what is a really awesome looking health record, but not actually understand the concrete terms that are in it? How do you get people to contextualize their own data in more simplified forms? And so while the Mashup Challenge was intended to help people to start on that process, we still have a long way to go. And so I guess what I'm trying to say is we really are looking for the innovation community to help us to begin to address those kinds of things. Because again, as this data becomes more and more liberated from the efforts of all of these folks on the table here, we're going to run into that challenge in increasing amounts. But the other thing that I find that some people sometimes forget is when you hear something that you've never heard before, like one of the first things you do is turn and you Google it real quick, right? And so a lot of times there are resources that are available that maybe an individual hasn't turned to yet. And so when someone comes back into you freaking out, I'd be curious to know how much, like what extra step did they do beyond hearing that word from you to sort of help their own edification, their own understanding of what it was you were trying to convey. So there could be a lot of market solutions to this, but there's also the sort of, don't forget that not every consumer is gonna freak out. A lot of us don't, you know. I mean, I understand where you're coming from in terms of that elderly population, but there is a significant opportunity for people to just quite literally turn and find a resource that can help them to understand.
Just a quick comment. The practice, so I still see patients from time to time, and the practice should be evidence-based. In this case, your question really centers around what the potential harms of sharing this data. 2 great data points we have right now are the Open Notes study that just came out in the Annals this year, and also the preceding one before that. I think it was called Sparrow or something like that, with heart failure patients. What they found in both was that these were legitimate concerns, so many physicians share these concerns. However, after they actually did it, they saw that in practice it was actually a very slim minority of the time, and it was exceedingly outweighed by the increased engagement and understanding that the patients had of their conditions. So I would encourage folks to look in those studies. If you're a provider on the fence on whether or not this is appropriate to do, just go back to the evidence and see what the data actually say.
Yeah. All right, let's take the next. I'm sorry, I didn't notice which of you was first. I think the gentleman in the back.
Hi, good afternoon. Hank Sandberg, Christus Health. We're a large Catholic health system. And I also have other responsibility as the executive director of the HIE in South Texas. So the comments here have me a little bit confused when I wear my HIE director hat. I'm not quite sure if this is going to help us or hinder us. We've been struggling with the cost of interfaces with electronic medical records to be able to connect across our community. So have the HIEs been involved in? I've heard consumer, I've heard provider, I've not heard a whole lot about the HIEs, and I have some private communications with CMS which indicate that the HIEs are an acceptable format for providers to achieve view, download, and transfer. So I could look at this in one way as saying that this could be a workaround for that, whereby they don't need to do that. So I'm a little bit confused. Can you address how the HIEs are being engaged in this as well?
Sure. So a couple comments. One is that we have worked with, as ONC, we work with most of HIEs within every state and territory. And we have had numerous representatives of HIEs who've participated in our pledge program and who are a part of this conversation, some of whom, for example, the state of New York is figuring out how to do personal health records that directly connect to the HIE so that they can be integrated as a part of this model. A broader comment, though, that I would get to is that what we're trying to do, I think, with HIEs on a very broad scale is to get the information flowing where it needs to get. And ultimately, if the consumer is the sort of HIE of one who ends up passing information from one provider to another, that works. That'll work in some situations. In others, you'll need more of the traditional HIE that links to numerous bodies within a state, numerous healthcare institutions. I don't think the answer is which will win. It's let's get the information flowing through whatever means works best and quickly.
And then for Automate Blue Button, I think it's an opportunity for HIEs just as it is for vendors and other healthcare providers. If you're interested in using the HIE to give consumers access to their data, Automate Blue Button can be a tool for doing that.
And I think you'll consistently see us. I just want to stress the point that Lygia made, which is that there is a need, absolute need for both. They both serve very, 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 very different use cases, right? The number of, for example, a lot of the reasons why we're doing the work around Blue Button is access around moving between different cities. Not just between your neighborhood, which actually an HIE would be a great way for an entire regional area to be in the same page, but the number of families that move across this country, the number of families that are in the Department of Veteran Affairs that actually move is quite a lot. And so both are needed, and I think if we as a community embrace both and see where each has its strengths, we'll be able to have even more meaningful conversations around it. So.
Thank you. And now the microphone in the front.
My name is Kathleen Charters. I currently work for the Department of Defense in the TRICARE Management Activity at headquarters. And prior to coming to Department of Defense a couple of years ago, I spent 6 years working for the VA on the My Healthy Vet Personal Health Record and wrote a lot of the language explaining to patients what Blue Button was and what it meant and what the limitations were. My observation is we do not make good decisions out of fear. When we're afraid, we tend to not make good decisions. And in my work with personal health records, both with VA and DOD, I hear repeatedly clinician concerns about, well, if we give them information, we'll be inundated. When we went to secure messaging, it was, I'll drown in messages. We found out after a year of experience that on average you got 3 messages a year from a patient. Mm-hmm. Nobody was drowning. When we released the lab test results, we hear clinicians fear saying, we need 7 days to get a hold of them if something's not right. They're going to inundate us with questions. They're going to see an abnormal and freak out. Well, we had a reference to lab tests online, and we said, look here first. If you don't find it or you don't understand, contact your primary care provider. We'll explain to you what's going on. They had almost 0 people contact them, maybe in the course of a year once or twice. You know, most patients went and looked it up. Those that didn't understand it would take it into the next visit and just say, oh, by the way, while we're here, I tried to find out, but it didn't make sense to me. Can you just help me understand? You know, 2 or 3 times a year that would happen.
Yeah.
So my experience in having done this for 10 years now is that we're not new at it, and people adapt quite well. And when you give patients information, they try and figure it out on their own first. I mean, for the most part, they just do. There's a handful that don't and won't, but they don't go to the grocery store and ask questions either. You know, and here's my final point. How many of us get dental bills that are explanations of dental benefits? Who can read that? Really, who reads their dental bill and understands what went on? I can think in the last 10 years that I've been going to a dentist, twice I've asked them about a billing question, just to understand what it was that I was looking at, twice. I don't think that's excessive.
Yeah, thank you for underscoring that. We may have to tap you for a blog post. But definitely, you know, the point has been underscored by the Open Notes Project, which Henry mentioned, and other things too. You know, years ago when people first started using telephones in medical practice, there was a lot of nervousness on the part of providers. What if my patients call me all the time, day and night? What if they call me when they're having a heart attack? What should I do? Same kinds of fears that you hear about the internet now that in fact turned out, you know, most people respect use of the phone pretty well, and I think that evidence shows that that's the case with other technologies. So this lady has been very patiently waiting a long time.
And I think our final question is...
I think this will be our final question as well.
Okay. My name is Elin Silvius, and thank you for hosting this town hall. I have a two-part question. For the many challenges and contests that the ONC has sponsored, where can we find information on the efficacy and effectiveness of the winners? Actually, one part of them.
Okay, was that the one? Okay, Pierce, do you want to answer that, or were you just?
Yeah, I mean, I'm not sure that most of those have been around long enough that the evaluation results are complete yet.
Because the program, at least at ONC, has just been around for about 1.5 years, if I remember correctly. So, but I can speak to the Health Design Challenge. If you go to the healthdesignchallenge.com bit, we're going to make sure to be as transparent as possible about all the entrants, how we're open sourcing it, the people that are using it. So if anything, if you're looking for the metrics in that world, you can see it there. For a lot of the video challenges and such, you can go, I mean, they're all the videos that people submit. They're on YouTube, so you can see their reach. So there are a lot of indirect ways to do it, but I do know that the team will, at the close of the challenge period of, I think it's like 2 years, they'll do a assessment of sort on it.
Metrics aren't efficacy. So for each of those challenge winners, do you have a research program rolled around? How effective are they? That you will
We don't have a specific evidence-based evaluation built into each individual challenge. However, we totally understand the importance of the point you're raising, and we've tried to incorporate medical efficacy where possible. For example, we had a contest which was co-sponsored with the Surgeon General's office in January of last year, in which we had folks submit existing apps and tools, and one of the criteria on which they were judged was an evidence base, and that they followed that. It's also been pointed out to us by a number of folks that it would actually be very useful for the developer community if we could articulate more clearly what kind, make that kind of an evidence, evidence about the evidence base more publicly available, so that as people are building new tools, they could really, take advantage of that. So
it may be helpful to
Yeah.
have for each one, like educational, behavioral outcome objectives for each challenge.
Yeah.
That's a great idea.
Thank you.
Thank you.
Thank you.
Good idea. Thanks. So we're going to wrap up. And as I mentioned, if you want to continue the conversation, we will be at the Cadillac Ranch at 186 Fleet Street at 6:30. And thank you guys so much for coming and for your questions and ideas.
Good to meet you.